Hi everyone, I'm Zoe. I'm 5 years, many of you know. Today we're going to be talking a little bit about autonomy, shared decision making, and the ethics of care. I have no disclosures. This is my grandparents' house. It is the house that my mom was raised in and that in many ways raised me. And I show it here because this is it at its cleanest and most organized. And the reason I show it is because hopefully it gives some explanation as to why I am the way I am, and why during this talk it's going to seem like we could be taking the path of the blue ant, but instead we're going to take the red. As many of you guys know, I spent a year during medical school getting a master's in ethics. So we're going to start with an ethical question that I think about a lot. How do we decide when surgery is right? Well, in the past, this was very simple. We just did. We saw the patient, we made a diagnosis, and we invited 20 of our best friends to come watch us do the procedure. However, as many of us know, this has not always gone as well as it could. And in the not too distant past, medicine and medical research have been the perpetrators of many different atrocities and violations of human rights. We're going to talk a little bit about a couple of those events, just to kind of get a sense of where we got to today and how we got here. So the first starts in 1912 with the case of Mary Schlellendorf versus New York Hospital. So Mary was a lady who presented to New York Hospital with abdominal pain and was thought to have a fibroid tumor by her doctors. She told them that she would under no conditions consent to a removal of that tumor, but she did consent to a examination under anesthesia, and when she woke up, the doctors had gone ahead and removed the tumor anyways. So she sued, and due to some kind of legal loophole, she actually didn't win much money from the suit, but as a result of this, the judge in the ruling made this statement: every human being of adult years and sound mind has a right to determine what should be done with his own body. And a surgeon who performs an operation without his patient's consent commits an assault. So this was the first time in the legal kind of jargon that this relationship between lack of consent and assault came from. Many of you know the Nuremberg trials. These were trials that were done after World War II, and this is specifically the Nazi doctors trial that looked at the experiments that were done by Nazi doctors and kind of the acts that they perpetrated in the concentration camps. From this, the Nuremberg Code came about, which you'll notice the first line states, the voluntary consent of the human subject is absolutely essential. And while this wasn't a legally binding code, it was one of the first kind of big ethics treatises that we have in history. And then the final one that we'll talk about is Mr. Salgo versus Leland Stanford Jr. This happened in the 1950s. Mr. Salgo was a man who presented to Stanford Hospital with bilateral claudication in his legs. And underwent an aortogram. And when he awoke from the procedure, he was paralyzed in his bilateral lower extremities. And his case kind of, he brought suit based on the fact that he had not been told that this was a possible outcome from the test, and he would not have agreed to it anyways. And he would not have agreed to it had he known. And so this case kind of helped to codify a lot of the requirements that we have for informed consent in the legal literature. Around this time, around the second half of the 20th century, there was the emergence of the Tuskegee trials and the kind of the rise of what we know as modern biomedical ethics in the United States. So on the left, this is the Belmont Report, which was the first kind of United States document that expressly spelled out ethical principles and guidelines for human subject research, and iterations of this and the common report became the foundation for the IRB law that we have today. On the right, we have the first kind of tome of medical ethics, modern biomedical ethics as we know it today, written by Beauchamp and Childress, who gave us the 4 principles that we all know dearly and love. Those, they actually were authors of the Belmont Report, and then went on to create this as a way of translating kind of philosophical ideas into practical recommendations for how to conduct ethical care within medicine. There was a lot of emphasis on autonomy in both of these documents. in part because there was a lot of kind of public outrage at the time for things like the Tuskegee trials, and the thought being that paternalism had been a big player in kind of allowing these things to happen. And in their book, Beauchamp and Childress rooted this idea of autonomy in the philosophies of Immanuel Kant, who up until this time was not as present in discourse. So why did they choose informed consent as the kind of the thing to emphasize? We talked a little bit about how it was a rejection of paternalism and physician decision-making, kind of something that showed that medicine saw what it had done in certain areas and was working on changing that. It gave an opportunity for patient self-determination, and it was evidence of an autonomous decision. So the idea behind it being that if you had had this conversation with this patient and they had agreed, then this was not paternalism, this is not something that you were doing unilaterally, that the patient had kind of made this decision, and so that gave you a little bit of something to point to if anything had gone wrong. And that's, I think, one of the things that is important to kind of think about when we think about where we are today with informed consent. They also gave us these wonderful 4 principles, which I think the first one on the top left is usually the one that we talk about the most, and then the other 3 are kind of the grab bag of write those. Talking a little bit about Immanuel Kant, because I think I'm going to rag on him a lot, but it's important to understand kind of where he was coming from and kind of the foundation of a lot of Beauchamp and Childress' ideas that they then kind of passed into biomedical ethics. So he was a German enlightened philosopher who believed that reason was the source of morality and that humans were inherently rational and moral creatures. And to Kant's credit, he did live his life like this. He was a very rigid man, and he personally felt and translated it into his philosophies that we all have an internal moral compass that is entirely black and white, that there is a universal morality of right and wrong, and that that's translatable across kind of the entirety of human interaction. So in Kant's world, a lie is a lie is a lie. If you should not lie at one point, you should never lie. And he was actually in search of kind of these universal principles of morality that he felt existed. The issue with this is that when you translate Kant's philosophies into practice, which they started to do immediately after kind of all of these things, it meant deciding that patients were entirely in charge of the decision-making process, that as long as they were making rational decisions from within their moral compass, physicians were tasked to act as technicians and executors, and not as any other part. So this changed the question to how do patients decide when surgery is right? I have only been doing this really for 5 years, but there's definitely some instances where I can think of where a patient's unilateral decision-making causes just as many issues as a physician's. He's here as a little bit as a hyperbole, but this is a man named Stellark, who is an Australian performance artist, who had a surgeon attach a cell-cultivated ear to his arm. This is him testing out his prototype for a bionic arm. And I think it speaks to a little bit of kind of, as the surgeon, when you act only as the technician, you may be put in positions where you're asked to do things that maybe you don't agree with or are not, in your opinion, in a patient's best interest. But in Kant's kind of conception of this, that's kind of irrelevant. This is a poem by Marsha Lynch about her experience with breast cancer that I also speaks to the other side of this, which is that unilateral patient decision-making can feel isolating for a patient, especially when they're dealing with something like cancer or something where they would like having someone there. So this was quickly, I think, realized as a problematic kind of 180 that we had made. And so starting just a few years later, there started being more and more talk about shared decision-making. So this is the first mention of it, which was in the 1984 Making Healthcare Decisions, which was a report published by the President's Commission. This idea of shared decision-making has been reiterated kind of more and more as time has gone on. It was listed in the Crossing the Quality Chasm, the publication by the Institute of Medicine, as a mechanism to ensure that patient values guide all clinical decisions. And actually today, it's one of the things that Medicare is now requiring evidence of shared decision-making processes in order to distribute reimbursement for certain things. But that begs the question, how do two people share a decision? So I'd love to hear, what does shared decision making look like for you? Does anyone have a schema that they think of? What is it?
Another model I found interesting is like a spine surgeon where, they make the patient beg them to do surgery, have to do all this, other conservative stuff, and then the patient's fine and please fix my spine, and then they offer surgery. So more of like the patient at that point is almost begging them for surgery to. Yeah.
I think that, the decision is ultimately the patient's decision, or should be, but the doctor shares the information with the patient shares their understanding of that and their values and what's important to them. And I think then the doctor is or should be in the process of aligning those preferences with which option fits their preferences most. And ultimately that enables the patient to make a decision. So it's a back and forth, but it's not I think the way the arrow is depicted is not exactly how it's optimally executed.
Yeah, I think there's like a component too that it's just keeping them taking their biases away, and it sounds weird to say making sure hope doesn't impact them too much, but they may hear there's a 10% chance of survival, and they conflate that in their head to think, oh, there's and I think some of it's kind of keeping them, a little focused on what's real and what's possible, and trying not to, I think they have a lot of cognitive biases that can also impact on it. I think it's also trying to make sure that they sort of, that has kind of a less of an impact on how they're doing a decision making.
So kind of, I think overall, we're going to talk all about this. It's tough with shared decision making. And I think when you come from kind of this philosophical perspective, there are a lot of issues that get raised about the application of shared decision making into the clinic setting and how difficult it can be in ways that are not captured by that diagram. So there's the idea of information overload, cognitive biases for both patients and physicians, kind of what you want to hear. Shared decision making assumes patients present with well-articulated values and preferences. Just have them ready for us. It ignores power dynamics between physician and patient. As Mohammed mentioned, there's a power dynamic of having the patient beg you for surgery. It ignores communication breakdown. Patients hear one thing and physicians hear another. It ignores time constraints, which I don't know that we're going to fix time constraints in our modern thing, but it definitely ignores them, as well as workflow integration. And I think one of the things that is most interesting is there's no clear nail-on-the-head definition or way to evaluate that we have of the sharedness of the decision, which I think is especially interesting if we're reimbursing people based on its presence. So kind of along those lines, while we don't have any kind of way to measure shared decision making, there has been a lot of research recently which has shown that there's at least indirect evidence that patients are not always satisfied with the decisions that they make after the fact. So there's been a lot more research kind of in each subspecialty of ENT and kind of all over medicine that looks at decisional conflict and decisional regret. And there, depending on where you look, are very high rates of these. You can see there's a 71% pool prevalence in this systematic review, 29% for cochlear implant satisfaction in this study here, 26% for older patients undergoing head and neck cancer. And while most of the research has been done within the head and neck oncology space, there has been kind of evidence of this found in each area. Additionally, research indicates that the model that we're using with this Kantian idea of the decision entirely from within the patient, the doctor presents the information and the patient has their suitcase of values that they then add into the conversation, isn't necessarily how things are actually taking place. There's evidence that external influences do play a role in surgical decision-making and in decision-making in general. And so that begs the question, kind of, are we doing this the right way? Are we going about this the right way? Are we thinking about it the right way? Which I think, as someone who does a lot of ethics, is what I think about a lot. So we're going to take a little bit of an ant detour now and talk a little bit about some alternative ethical frameworks and ideas that might be able to help with some of the issues we've discussed in shared decision making, and how they can guide kind of additional research and innovation in this space. So this is Lawrence Kohlberg. He, in the 1970s, was working at Harvard trying to create a theoretical model of moral development, trying to understand how people become moral bodies and moral entities. And you'll notice he came up with this 6-stage model. And at the top, there's this idea of principal consciousness, which I think kind of relates to what we think about with Kant, with the right and the wrong, and justice-oriented, principled, doing away with external factors kind of mindset. Lawrence Kohlberg had a research assistant named Carol Gilligan, and Carol Gilligan was working with a lot of his research subjects and doing a lot of interviews, and she began to notice that there was a certain subject of people who never made it to this 6th level, who, no matter where they were in kind of their moral development, would always, or in their age and how it relates to their moral development, would always tackle moral dilemmas with a focus on kind of relationships and responsibilities towards certain people and environments, and less so on the abstract justice and fairness of a situation. At the time, the sample that she was working on was primarily women, and so she attacked this or started to think about it as a separate framework, as a separate idea. It's actually been shown that in studies of ethics of care after that there's not really a gender discordance here, but I think she definitely wanted to kind of explore this and kind of counteract this idea that was coming out of Kohlberg's research that women did not achieve this higher level of moral development. So she created something called the ethics of care, which was her alternative philosophy and idea of how people were conceiving of this morality. And the ethics of care is basically it focuses on context, it focuses on relationship, and it emphasizes obligations to attend to the needs of others. It places empathy and emotional responsiveness within the context of moral reasoning. And it creates kind of an alternative framework in which people can morally target issues without kind of trying to do away with external influences, instead of kind of saying, we're going to try to find this ideal framework in which we get to a point where we're not impacted by relationships, we're not impacted by emotions, we are not impacted by this. It draws all of that in, and it says we're going to include all of this in the conversation, and we're going to use it. So this theory was then taken up by two ladies, Ruth Macklin and Susan Sherwin, who created this concept within their conception of the translation of the ethics of care to medicine called relational autonomy. Relational autonomy recognizes a person as socially and historically embedded, not metaphysically isolated, and it places people within the context of their environments and creates an emphasis on the potential for empowerment. And the goal really of relational autonomy is to use the lens of the ethics of care to gain a better understanding of the context and the connections that patients enter the clinic already embedded within, and try to find a way to use that and use the knowledge and privileges of the doctor-patient relationship for empowerment. And I think it's important to kind of state that this does not deny the concept of autonomy. Patients are still autonomous. Autonomy just becomes redefined as this social project that it is. So we're going to talk a little bit now about how applying these concepts of relational autonomy gives us a little bit of a more nuanced understanding of the interactions that we have in the clinic, and provides us with opportunities to kind of gain further insight and improve patient interactions just by shifting the lens from one that tries to shed those external factors to one that brings it in. I think it's important to note that we already talked a lot about, just in passing, concepts that are going to come up in relational autonomy, and it's things that are probably not going to seem groundbreaking, that are things that we already do kind of intuitively in order to kind of do the best that we can for our patients. But I do think that it's helpful to have a framework in some ways because frameworks can help you, especially when things don't go well, when you're trying to figure out what in a conversation or what in a situation didn't go as well as you had planned. So this is kind of more of a realistic model of what a relational approach to a healthcare conversation would look like. And it's overwhelming, and it makes you feel like you're definitely not going to have enough time. But I'm just going to go through a couple ways that we can kind of target each part of this and ways that it changes kind of the traditional approach to autonomy to something that I think is a little bit more pragmatic. So we're going to talk a little bit first about the doctor-patient relationship. And then we'll talk about the social cultural context, and then we'll talk a little bit about time. So the language of medicine kind of inherently creates unequal footing. And relational autonomy causes us to recognize that patients and doctors who enter the clinic are both embedded within their environment, and that as a result of that, as physicians, we're always going to understand more about what we're talking about than our patients, because we live it, because we are embedded in it. Even when you're talking to a physician in a different subspecialty, you're still always going to understand more, and maybe you should remind them. This is a text message that is me trying to very much hedge advice I was asked to give on swollen toe. But I think it's an evidence of kind of like how easy it is to forget how much this common language is and just embedded in our brains. This is probably my favorite piece of feedback that I've received during residency. And while I have not grown at all in these 5 years, I have noticed that the conversations that I have and the words and my opinions with patients is differently received now that I am older. And I think that speaks to the fact that there's a certain amount of authority that comes with being a physician and a certain amount of vulnerability that comes with being a patient. This is shown in the research. So this is a study that was published in JAMA, Journal of Medical Education, which they asked basically patients online what reasons for not telling their physicians were. And I think I just pulled a couple out of their table, but a couple are, I didn't want the healthcare provider to think I'm a difficult patient. I didn't think it mattered. I didn't want the healthcare provider to think I'm stupid. I wanted the healthcare provider to like me. So these are certainly not things that I'm thinking my patients are thinking when I'm speaking to them, but they're clearly things that people are thinking. And I think that's an important thing to think about. It's a lot of thinking. This is another paper that came out earlier this year that showed that perception of power asymmetry or power differential increases decisional conflict and decreases the patient's willingness or interest in participating in shared decision processes and sharing of preferences. And as we talked about, breakdowns in communication occur, and not thinking about these power differentials and the communication disparities that we have can have implications for care. So this is a study from 1996 where they interviewed doctors and patients after a clinic visit and kind of asked them what their perception of the information that they were given. And I think it's interesting to note that here you'll notice that 23 of the 100 patients interviewed in situations where patients thought there was a 50 to 99% probability of cure, physicians thought there was 0. On the right, we have another study that was done by a group here at Stanford, which talks a lot about the word treatable. And it shows that the vast majority of physicians, when they hear the word treatable, think about an action-oriented idea. We're going to treat this. We're going to give palliative radiation. We're going to do something for it. Whereas patients view it as good news, as something that is a great thing that has happened within the trajectory of their disease. So I think that these things are definitely important to think about. So the Kantian kind of reaction to this would be, well, we need to give them more information. We need to figure out a way that they can figure out how to learn more and take it in, because ultimately they are the deciders. And I think we know, and certainly I know, that the decisions that we're making are complicated, and they're only getting more complicated. And I think it's a large ask to ask someone to learn in 15 minutes what it took you or took me 10 years to learn. And so these are, just different decision schema for CRS, for vestibular schwannoma. And I think it's kind of, at some point, kind of not a feasible idea. So if we take the relational approach to this, the question becomes not how do we educate people more, but how do we do so in a way that empowers them from their relationship with us. So this is Louise Davies' TRIO thesis, where she looked at decision-making in head and neck cancer care. And she found that providing risk-benefit information alone did not change patients' decision, but providing patients with the data that was directly relevant to their lives, that kind of articulated what a certain thing would mean for them, did. This is another study that was a systematic review that kind of spelled out in one of their figures the difference between knowledge and power. This idea that giving people more knowledge will empower them to make a decision versus giving people the knowledge that they need and empowering them to interact with you in that decision. There's been a lot of work that's done on this in the general surgery and vascular surgery kind of areas by Gretchen Schwarze, who has spent a lot of her career kind of trying to figure out how we can better communicate with patients in order to empower them, in order to give them kind of the information that they need to act and that they're looking for. And so these are kind of some things that she has pulled out from her research. The first is show your cards. So I think a lot of times when we have a particular opinion about a treatment, we are hesitant to say it because there's this concept of shared decision making and letting the patient decide. But oftentimes I think research has shown that you will find a way to make your opinion known whether you want to or not, whether in the way you ask the question, in your nonverbal body language and things like that. And so Dr. Schwarze's kind of thought with this is if you tell people your opinion and tell them where you're coming from and just couch it as that as just your opinion, not something I'm certain about, this is what I think, then that gives them a little bit more of a sense of it, removes the unknown of what is my doctor thinking. Identifying and naming uncertainties. Patients are not always sure in her studies what we are and are not sure about, and it's important to make those things clear. Presenting goals and outcomes rather than technical details. Patients, as Dr. Schwarze talks about, don't really care what you're taking out of their body if you're not telling them why it's going to matter to them. So excessive details about kind of, then we will elevate the submandibular gland and that type of thing is only relevant to them if they have a sense of what that's going to mean for them after. Giving probable downsides as well as worst case scenarios. This is something that I struggle with a lot of, differentiating the things that I think are actual risks of the surgery versus the theoretical risks that exist in any surgery. And then when possible, giving time for deliberation. So that's something that I think taking patients outside of the context of the healthcare system and giving them some time to think about things within their own context is also helpful. Gretchen Schwarze's research is done mostly in the vascular and ICU spaces, and so it doesn't tell us a lot about quality of life. This is a study that I'm working on with Dr. Sturmer and Dr. Holsinger, which looks at the patients who are asked to make the decision between TORS and radiation and tries to understand kind of what they're considering. Cure is less of a question in these conversations, and kind of the mechanism is more of what's important. And so by trying to get a better understanding of what patients are valuing, what relationships they're thinking about, how they're making this decision, we can get a better understanding of how best to guide them, how best to understand what information they need. And that's something that I think we can do in a lot of different settings. Relational approaches to the social context. So one of the things that we often struggle with in medicine is knowing how to deliver culturally competent care and how best to help people with vulnerabilities that are created by the social systems in which they are embedded. And I think relational approaches can give us a little bit more of a perspective on this. So there's lots of stories out there of kind of times when we weren't able to figure out the dynamics and the relationships and the importance. We read about one this year. But I think it's also one of those things that you can think about a lot with culturally competent care. So I don't think that this is going to come as a surprise to anyone, but relationships shape a lot of cultural norms and can be key to understanding cultural preferences and decision making. This is a study that was done by Arden Morris and her team here, which was just a systematic review for cancer care among racial and ethnic minorities. And I mostly show this because I think the schematic that they came up with is very similar to kind of the relational frameworks that we've been seeing. And then I think there's something to be said about the goal of empowerment within the setting of relational autonomy. It's not a surprise that people from communities that have been in the past mistreated or harmed by the medical community are going to have higher rates of distrust and need for stronger relationships between practitioners and providers, and a commitment from a provider to do that is important. And then addressing these understanding these barriers to care and care decisions can help us address these barriers and empower patients in the decision-making process. This is a study that I've been working on with Dr. Balakrishnan, and basically it's the title of it is Empowering Bidirectional Regional Academic Community Engagement in Surgery, which is embraces. It's a mouthful. But basically the goal of this study is to better understand how we can serve primarily Spanish-speaking patients whose children are recommended to undergo tonsillectomy, but who do not end up getting the procedure, and trying to figure out what are the barriers to care there. So we've been working with community health worker programs. This is called the Promotores program, which is a primarily Spanish-speaking community healthcare worker program that works with these families to kind of try to figure it out. And through interviews, this is the concept map of what we've kind of tried to figure out is what are the biggest decisional barriers to care. And there are certain things that as physicians we're challenged by. So resource challenges are things that we struggle to kind of meet. But there are certain things that kind of we can think about and actually target, and having a relational understanding of how those things relate back to us in our interaction with patients in clinic is important to kind of start with that. You'll also notice here that there are just purely relational factors that are going into this. So this obligational idea of the opportunity cost of time, the impact of surgery on family, and the needs of other children, all as being barriers to care for one children, is something that I don't think we could understand from the Kantian framework. Similarly, decision needs, this idea of having trust in the practitioner being someone who can help embolden and enable patients to kind of undergo this surgery. That's also something that I think we see a lot. And so finally, we'll talk a little bit about relational approaches to end of life. So I know I've been ragging on him a lot, but Kant was a very rigid man, as I've said before, and he was so rigid that there's a legend that he used to take the same walk every day around this tower in his hometown of Königsberg that he had never left. And he would do it so much like clockwork that people would actually set their watches to him taking his walk. And so I don't think it should come as a surprise that Kant's view of decisions, where the decisions that you will make at one point in your life are the decisions you will make at every point in your life. And that there is no kind of room for change and room for anything. But research shows that that's not necessarily true, and that's especially not true in terms of end-of-life care. So this is a study that was done of Hopkins or graduates of Hopkins Medical School doctors when they were in their 50s and 60s, and it's just a survey that was sent to them with a span of 3 years, asking what they would want for themselves for end-of-life care. And as you can see, there are changes here. People change their minds in terms of the amount of aggressive care they would want, and the types of aggressive care they want. And relational autonomy gives us a way of understanding this. In relational theory, selfhood is seen as an ongoing process rather as something that's static and fixed. And I think this is especially important because the experience of something changes our perception of it. I always use this story because I think it's just kind of fitting. This is Peggy Batten. She was one of the preeminent kind of ethical scholars on the issues of physician suicide and physician-assisted suicide. Sorry, not physician suicide. And she wrote a lot about kind of this, her advocacy for it and how she felt that it was something that should be given to patients unilaterally and that should be their decision. And her husband actually, unfortunately, had an accident, a biking accident, in which she became quadriplegic, kind of at the midpoint of her career. And at some point in his recovery, he actually requested to be allowed to die. And she writes a lot about what this meant for her and how it changed her perception of things, how she had spent her whole life talking about physician-assisted suicide, but the fact that it had gotten personal and that it had happened to her changed her perception of it a lot. And we see this in research too. So while most research shows that patients who are terminally ill are less likely to change their preferences during their terminal illness, we have a lot of data that shows that patients who are healthy make different decisions than patients who are sick. So the experience of being hospitalized, as you can see on the right, changes your perception of what you would want at end-of-life care. And so that's something where we're evaluating a lot of patients and we're not thinking about kind of the temporality of these changes. And so one of the ways that relational autonomy can help is it challenges the ideas of permanence that exist in much of our current perception of end-of-life care and acknowledges that relationships and situations change over time and that there are nuances that we need to continue to evaluate as we try to understand preferences. I think there's a lot of opportunities for understanding preferences in end-of-life care especially and understanding them within a relational framework. When we think about studies like this, which is a study from the Hopkins group that looks at priorities and concerns and regret among patients with head and neck cancer, you can see that cure is the number one thing that's prioritized. And I think that's probably something that we see in a lot of our populations. Interestingly, survival is less prioritized as you grow older. But relational autonomy kind of, and I think that the examination of end-of-life care in general kind of asks us what would change if there is no longer cure as possible. Can we do these studies again and try to understand which of these things start to matter to you more when the cure is taken off the table? And can we go from there to understand the interplay of relationships and patient preferences that shape people's end-of-life wishes and create a more kind of tenable system for kind of dealing with end-of-life care. So, in conclusion, this is my attempt at the Blue Ant. Traditional conceptions of autonomy and informed consent reject paternalism, but may not really give us a tenable way of dealing with a realistic sense of shared decision-making. And relational autonomy frameworks can open up new areas of studies and give us an alternative lens that augment that process of shared decision-making and help us better understand what our patients are bringing into the clinic with them and what we are also bringing into the clinic with us and how those interactions take place. And like many areas of medicine, we need more research to understand the decision processes of patients and delineate how we can create environments that encourage these shared decision-making. And that is, there's a million people to thank, and it seems weird to say thank you in April, but thank you all for